I forgot to put myself up. I'm sorry. Hang on. I'll be very quick. I'll be very, very quick, sirs. Fuck. Okay. This one. Sometimes I regret doing this stupid thing. Okay. Hello. Here, there. It's everywhere. Okay, let's fix stuff. Cause you know. This is bullshit. Here we go. You and then me. Why am I up there? I should be here. Okay. It's not oxygen therapy anymore. It's, you know, X-ray interpretation. Yes, very important. As us healers, we have to know how to interpret stuff. Okay, let me put up new Mobot. Play, keep. There, 1, 2, 3, bam. Fucking okay. I mean, at work I've done, you know, these things. So the X-ray of the lung, left and right lung, I've seen it before. Fissures, you can't quite see them unless there's like consolidation. This one I've seen it. Pneumothorax, hemothorax, supine films, I've seen it. Pleural effusion, silhouettes, alveolar collapse, and atelectasis. The fucking heart is even gone. And not gone per se, but it's collapsed. So it is very difficult for the patient to breathe. It is a problem. Okay, let me put up my phone so I can manage my shit as well. Where the fuck is Twitch? There we go. Mediastinal shift, trachea shift. Yes. Okay. Okay. Signs of collapse. This whole thing is gone. So this is the carina, and then, you know, we can't even see the top lobe of the lung clearly, so we can't. It's collapsed. So, and you know, the carina, the trachea is shifted towards the right, so you know, interpretation. Yes. See, very easy, very easy. Yes. And then signs of collapse, we'll see. Okay, the mid lobe is collapsed. You can already see. Yes. Signs of collapse. The bottom is gone because, you know, the claustrophrenic layer isn't down there. It's up here. So the lower lobe is collapsed at the right lung. Well, I'm not quite sure for the middle lung, but, you know, at least this one is, you know. Okay. Wait, after a fall? What did it say? After a fall? What? How come? I didn't know when you fall, your lungs can collapse. The whole damn left lobe is left lung is gone. God damn it. Lung consolidation and pneumonia. Yeah, this one. Which means the whole lung is being flooded by fluids, okay? You know, the alveolar, the little, like, broccoli ends of the lungs, you know? All of them are being flooded, though. Yes. Bronchiograms. Tubular outline of an airway. Consolidation, atelectasis, blah, blah, blah. How come? Conditions may result the appearance of bronchiograms include pneumonia, atelectasis, and yeah, you can already see these little like hilar things, like, you know, these little stems of the broccoli. Bilateral pulmonary infiltrates. Yeah, look at these. Everything's so fuzzy. Cardiac cause, acute pulmonary edema, which means the pulmonary artery like has like a really high pressure, so yeah, you know, the fluids are gonna squeeze into the lungs, so, you know, they fill up the lungs. So non-cardiogenic include acute lung injury and acute respiratory distress syndrome, inflammatory response with the lung parenchyma. Generally not possible to differentiate cardiogenic versus non-cardiogenic cause of bilateral pulmonary infiltrate from the view of chest x-ray. Well, shit. Parenchyma changes. Let me blow my nose every single time. I need to blow my nose. I don't know why. Inspection of the lung parenchyma may reveal abnormalities. Lung bullae. Lymphomatous bullae result from dilated structures with significantly reduced potential for gas exchange. Hey, I mean, I've seen, but you see this little big hole here? Like, it's extra dark. Like, you can see these things are kind of like grayish, but this one, like maybe this one here, there's a bullae here. Yeah, these are large bubbles. Like, the alveoli are melded together. They form one giant balloon. Infected fluid level within cavity. Trap air causes pneumothorax. Increased density. Damn, what is this? Is it a tumor? Oh yeah, it is a tumor. Aspiration of metallic what is this thing here? Lines and attachments. NTT. Now you can see all the tubes. This is probably, you know, for the ECG thing. Ventilated. ETT, NGT. Damn, everything's in her throat. Pacemaker. ECG. Catheter in situ. Now this whole thing is popped, so they need like a chest drain to drain out the air. Subcutaneous emphysema, collapsed left lung. Okay, we'll see. Review the following X-ray on spare piece of paper. Describe pathology you're able to see. Systematic approach. So A, airway. This is apparently hyperinflation. The bones are fine. Yeah, the bones seems fine. The heart seems fine. The shape is here. The claustrophrenic angles and cardiac cardiophrenic angles are fine. Aortic arches here. Carina's here. Hilum's here. Nothing blocked. Those bones are fine, but you know, the only you know, visible thing is you know, the ribs are quite flat. So 1 2 3 4 5 6 7 8 front. Let's see, 1 2 3 4 wait, 1 2 can't see, 1 2 3 4 5 6 7 8 9. Yeah, 9 posterior. So this is a hyperinflated lungs. Mediastinum long and thin. Yeah, hyperinflation. Yeah, not the COPD. Like, we can't quite diagnose COPD with, you know, just a, you know, what's that called? An X-ray. Okay, maybe the following X-ray. Let's see, lines like ECG, possibly. You may also be able to see the NTT tubes. Maybe. And you can kind of see... Is it another hyperinflated lungs? Wait, there is a little bit of collapse here, like at the top lobe, you know, here. There's like air here. Let's see. 1, 2, 3, 4, 5, 6, 7. Kind of. This is... Yeah, and the heart is set like slightly more middle than it should be. Angles are not that... you know, are not that, you know, apparent. Maybe a little bit of edema. Because, you know, the lung is a bit too white to me. Collapsed lung. Apical, yeah. Polymer infiltrates hemidiaphragm, not visible. Right upper lobe, visible lung border, lack of bronchial, blah blah blah. Infiltrates with hemidiaphragm not visible. Yeah, I was correct. Lines, NT tubes, balloons, left clavicle. NG tube. Okay, yeah, I was correct. Okay. Question 3. Which is the patient of post-laparoscopic abdominal surgery normality? There's gas underneath the diaphragm, but it's quite normal for a laparotomy, like a surgery within the abdomens. But it will go. It will go away soon. Heart is fine, lung is fine. It's slightly rotated to the left, no, to the right, sorry. 1, 2, 3, 4, 5. No hyperinflation. 5 to 6, so it's fine. It's fine, looks fine. Beneath bilateral heavy diaphragms, it's normal. Yeah, it's just everything's normal. Systematic approach, blah blah blah. So airway, another hyperinflated lung. This is a gastric bubble, so it's fine. Airway, bones, breathing, no tubes. Cardiac, it's fine. Diaphragm, quite flat. Exposure. 1, 2, 3, 4, 5, 6, 7, 8, 9. Quite flat. Another hyperinflated lungs. Gastric bubble. Thoracic scoliosis. Okay. Wait, I thought it's hyperinflation again. Scoliosis. Wow, very severe like kyphosis though. What are these little things here? One. Let's see. No. 1, 2, 3. 1, 2, 3. Wait, the posterior is more better. It's better. But 1, 2, 3, 4, 5, 6, 7, 8. Is it another hyperinflation? Kyphosis. You know, this is quite like foggy, so it might be consolidation. Enlarged size, kind of cardiomegaly. Okay. Question 6 to 10. Let's see. Whoa, collapsed lungs here, collapsed lung here. Damn. Wait, no, it is actually the fluids at the top. This is collapsed. Clavicle, bones are fine. Bones are fine. Hilar are present here, except here, like at the top bit. This is fluids at the top, top lung. So let's see. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Is it another hyperinflated lung? Not quite, but you know. There's like NG tube, like endotracheal tube as well. That's quite close to the carina. No wonder this is collapsed or something, because, you know, the air goes here, not here. Mediastinum shift to the right. Yeah. The heart is about half. Upper lobe collapse. Left apical pneumothorax. Yeah. It's all air in here. Okay. Question 7. Review the X-ray. Whoa, this whole thing is gone. Like, a lot of, like, consolidation going on here. Heart is more or less here, which is fine. Pleural effusion. What is it? Because of the meniscal line here? It's not too, you know, obvious though. Right thorax. Here, X-ray. Pleurodesis. Fine. Shifting to the cardiomegaly, or shifting to the left. 1, 2, 3, 4, 5. Not quite. NT tube. The NT tube is here. The NG tube is here. I don't quite see what this is. What the fuck is this? Subcutaneous emphysema. Really? Well, maybe a little bit here. Right chest wall. Insertion of... Okay. Intercostal catheter. This one, maybe. Shift to the left. Maybe. But it's so difficult to look at, though. Collapsed left lower lobe. Not too... Yeah, because this here is not too obvious, though. Left diaphragm. Endotracheal, ICC. Okay. X-ray. Another hyperinflated lung. What the fuck is this? Increased mediastinal shadow. 2, 3, 4, 5. Wait. 1. Wait, 1, 2, 3, 4. 8. No. Kind of. NG tube down here. Damn, there's a like pleural effusion here. You can't quite see anything here. Talic knob. Oh, nipple ring. Hey, mediastinum. It's shifted towards the left. Ribs crowding. Lower lobe collapse. Consolidation. NG tube in situ tracking down stomach. Oxygen tubing visible. Okay. Okay. There. We're done. Okay, let me just, you know, hide things a little bit. Whoop. Okay. Next one. We have to pick the fault, like another. Okay, let me see. Let me see what she wants me to do. Let's see. I need to find. Wait, where's the? Where the fuck is the email? Oh, here. Okay. I need to find my email. Let's see what she wants. No, not chat. God damn it. Organ donation, my ass. Let's see. Where is? For fuck's sake. Here. Enhancing. No. Fuck. No. Oh. I need to open the email. Ew. Can't believe, like, after work I have to deal with this shit. Chest. Airway suctioning via. Okay. Browse for more courses. Airway suctioning. Yeah. Yeah. Okay. But I'll have to remind myself to, you know, turn on the thing. Otherwise, nobody's able to see anything. Okay, start online course. Hello? Okay. Launch course. Still loading. God damn. Okay, there we go. Show it. Not Twitch. Where the... Wait. Oh, here. Okay. Let me change... text. No! Oh my goodness. Suctioning. Okay. There we go. Airway suctioning via blah blah blah. Let's get started. Okay. Learning objectives. Treatments for suctioning via oropharynx and nasopharynx. For fuck's sake. Methods available to suction via this one. Aware of the indications, precautions, and contraindications. Okay. Can be used to restore airway patency by separating the tongue from this one. Below my nose again. Adequate oxygenation through providing an avenue for adequate ventilation. Provide access for the removal of secretions in the upper airway via suctioning. Healthcare professionals. Insertion of NPA-OPA indicate for secretion removal in patients who have evidence of secretions in their upper way. Absence of cough reflex or impaired ineffective cough. Often reflects patients who have an altered conscious state, are weak and neurologically impaired. Okay. Audible upper airway transmitted sounds, muffling of a patient's voice by secretion. Transmitted sounds on auscultation of chest wall, tactile phrematous, moist and rattling cough. When these signs are present and the patient is unstable to clear secretions via voluntary and stimulated by any other means. Okay, suction may be indicated. Wait, okay, let's shut up. Moobot, stop okay, let me go drink. I need a drink. Oh, for fuck's sake. Where am I? Why am I not here? Hello? Where did I go? Why am I not here? Wait, hello? Okay, I'm back. Oh, muffling, hey? Let's see.
And can you say the alphabet? First few letters of the alphabet?
A, B, C.
Cool.
Yeah.
Can you give me a nice big cough?
Jesus.
Good work. Excellent.
Let me let us hear that for another one. Okay.
And can you say the alphabet? First few letters of the alphabet?
A, B, C.
Cool.
Yeah.
Can you give me a nice big cough? Good work.
Damn. Drowning in sputum. Post treatment.
And your alphabet?
A, B, C, D, E, F, G.
Excellent. And can you give me the loudest ah?
Ah,
Beautiful. That feels much better?
much of yeah.
Yeah. Congratulations. Assisted cough maneuver. Manual application external force to chest wall. Significant neuromuscular impairments. Manual thrust may be applied over upper abdomen. Subcostal thrust in patients with spinal cord injuries. Involved using mechanical insufflation, exsufflation. Cough assist nippy. Covered in this resource, considered in patients who have very poor cough strength. Cough stimulation may be done by tracheal rub. Soft tip Y suction catheter technique. I don't know what that is. Cough assist maneuvers, simulation techniques implemented or utilized by physios. Manual assisted cough. Okay, so lower ribs, just ooh. The Heimlich one. Okay. Down and in, okay. Inward. Okay, AP pressure. Upper anterior chest wall, subcostal thrust. Significant weakness in the abdominal muscle. Okay. Okay, simulating a cough. Okay, tracheal rub. Soft tip Y section catheter, hey. Wait, let me put on the music again. Okay, firm flat pressure of finger and thumb, roll across trachea above the suprasternal notch. Flat firm pressure, okay. Oral pharynx. Along the outside of the teeth and around into the back of the oral pharynx. Catheter is passed along the side of the teeth. Block is commonly felt when the catheter comes in contact with mandible. Rotating the catheter gently will allow the catheter to move off. Passing directly over the tongue, stimulate cough reflex. I see. Prevent need of suctioning via the nose or with a Goodell airway. OP suction. Okay. By selection of NP suction or OP suction. Damn it! Fucking hell. OP suction. Goodell airway. Rigid PVC tube flanged at the mouth end, shaped to conform to the curvature of the palate. Properly, the flange sits outside the lips, and the tube keeps the patient's tongue extended and prevents it from opposing against the posterior pharynx. OP size like around from the lip to the ear lobes. Push the tongue back. forcibly inserted. Generally reserved for patients who have lowered unconsciousness, as aspiration may result in those patients who are semi-conscious awake gag reflex. Okay. Should not be used for patients with strong bite reflex. The lever to try and pry open a person's mouth if they're biting. Commonly describes as matching the length of the airway to the distance between maxillary and central incisors. Corner of a patient's mouth to the angle of jaw. Okay, use of incisor. Reference point more effective. Okay, distance between maxillary, central incisor, and the angle of the mandible. Okay. Okay, opiate suction. So as I remember, you just like, you know, the hook faces upwards, then put it in around in the middle, just twist it 180 degrees so it would face down. Explain procedure to patient. 5 moments of hand hygiene. Don gown, gloves, and goggles. Standard clean technique. Suction the oropharynx and inspected for possible obstruction. False teeth. Insert the OPA. Measure the OPA against the patient's face. Angle of jaw to central incisor. Initially, the airway goes upside down. Okay, with the distal pointing to the roof of the mouth. Pushing the tongue back into the oropharynx during insertion. Back of the rotated. Yeah, just as I said. Proceed with airway suction. Lubricate the tip of Y suction catheter. Stimulator to vomits. Prepare to suction the patient's mouth with a yanker and turn them to the side if necessary. Duration of use. Okay. Now this is too short. Wait, is it too short? Oh, well, the angle of the mandible, so... yeah, upside down. Yep. Very good. Insertion variations. Okay. Position in airway. Oh! Already in there. Insertion, rotation, suction. Okay, inserting the airway into the oropharynx on the side rather than upside down. Twisting 90 degrees then 180. Prevent trauma to the posterior pharynx if the airway is inserted forcefully. No shit, Sherlock. To the side. Down. Okay. NP suction. With or without the use of NP. Preferable in patients who have evidence of retention and where quantity require frequent suction can be performed. Quantity, okay. Poor nose though. NP a robust, supple but kink-resistant tube made of soft rubber, flanged at the proximal nasal end. Properly placed, the tip rests behind the tongue, just above the epiglottis, having separated the suction catheter can be passed through. Not stimulate gag reflex. NPA better tolerated than OP in conscious patients. Left situ. Okay. Trismus and convulsion. Correct NPA size. Length of NP more critical than its diameter. NPA research, blah blah blah. 150 cm, so 15 centimeters. That passes a lot of stuff. Because the pharynx around like hits around like 11 centimeters of the catheter, I think. 130 for females. Distance from what the fuck is a filtrum? Okay, let me see. Filtrum. What's a filtrum? Oh, this one. This is the filtrum. Like, you know, the groove between your nose and your lips. Filtrum to the tragus of ears. I see. Okay. Duration of use. No clear evidence of blah. Yeah, where where is that? I never used these kind of NPAs because they never provided. But wait, what the fuck is an NPA? Oh, Nate, NP airway. Clinically indicated it can remain for up to 24 hours. Pressure areas switch the NPA from one nostril to another every 68 hours. Inspected regularly for pressure areas, blah blah blah. If a patient requires suction regularly and frequent, 1 to 4 times a day after treatment, then reinserting the airway before each suction. Wait, reinserting the airway before each suction procedure or performing suction without the NPA might be appropriate. Okay. Copious. Twice. NPA and leaving it in situ is warranted to permit easy access, minimize trauma. NP insertion. Corrected surgeon. 5 moments hand gene, like hand hygiene. Hand gene, what? Let me blow my nose. Inspect the nose for septal deviation. Exclude obvious nasal polyps in either nostril. Septum is deviated to one side and easier to insert an airway to the opposite side of the deviation. Determine the length of NPA use of safety pin. Cited being supplied within package for some NPA device. Recommendations for the safe use of safety pins may vary between hospitals. Check with your local site procedures. Despite an NPA being heavy flanged and their inadvertent migration into the NP has been reported. For inserting the NPA, consider use of a medium-sized safety pin placed through the edge of the flange. What? Passing suction catheter through NPA may also cause the device to migrate. Lubrication of the Y suction catheter with a water-based lubricant before inserting it into the NPA. FG10 catheter. Supporting the airway prevents migration into the NP. Will place the safety pin through the lumen of the NPA. Prevent insertion of suction catheter into the lumen. KY jelly. Initially choose the larger nostril if it's clear from other tubes. Insert the tip of the NP into the nostril and slightly lift the nares up. And direct the airway to follow a path along the floor of the nose parallel to the hard palate. Gentle partial rotation to the NPA if resistance is felt during insertion. Opposition against the turbinates. If this does not relieve the resistance or obstruction, then withdraw the airway and try the other nostril before selecting a smaller size. Insert the airway until the flange is rested. What the fuck? Shut up. Just, you know, do not disturb. Yes, it's very important. Lubricate the catheter prior to insertion. Too wide. Yeah, NPA correctly. Lift the nares up. Nasal airway advancement of the NPA parallel to this one. Rotate NPA resistance is felt. It should also rotate easily when correctly placed. Repeat in situ. I never do this. Like, no one ever provides me this with that. Reapplied when the suction catheter is still in situ. Copious secretions are present. Desaturation occurs or gives the patient a rest during the procedure. Suction without NPA. Well, I always do this, so. Nasopharynx can also be performed without the use of NP airway, preferable in patients have evidence of secretion retention, but where the quantity of secretion may not require frequent suctioning to be performed. Y suction catheter can be advanced in similar manner described previously with this insertion of NP airway. Lifting the nares. Reveal the nasal air advancing the catheter parallel to nasal floor. The Y suction catheter passed into the NP until a cough is obtained. This is generally after the catheter had been passed a short distance further than the distance that can be gauged from the filtrum. But okay. Consideration for insertion. Okay. Damn, there's a lot of them. Airway suction retained. Yeah, usually if the patient, you know, can cough, like, or if I can clap it out, then I don't really need to provide suction, but you know. Ew. I wanna die. I wanna die. Contraindications. Review the patient's medical history. Identify contraindications. This does not tell anything. Seek approval from medical staff prior to insertion suction via NP or Guedel airway. This does not say anything. So later on I learned that, like, you know, if the patient has coagulation problems with the blood, like INR and like APTT, like higher than a certain number, then, you know, no suctioning. Okay. Excellent. But, you know, just in case, ask the doctors. Explain the procedure to the patient and family. Yeah, shit. Don appropriate PPE. Position. High supported sitting. Support the airway. Hyperoxygenate. Prevent DSAT during suction procedure. Already low SpO2, no desaturations or intermittent pie suctions. Okay, I always do that. Prep. Clean gloves, appropriate size, suction equipment functioned, turned on. Yanker. Insert the airway. Okay. Assess. Look. Listen. Feel. Pulse oximetry. 2 people will be required. One to hold the airway in situ, reassure the patient, while the other person perform. Okay. No shit. Always 2 people, hey. Once a strong cough is stimulated, generally after the catheter passes short distance, blah blah blah. In some cases, a cough may not be stimulated. May be inserted further until secretions are found. When inserting the Y suction catheter further, not possible to know its true course. Care should be taken. May enter the esophagus and the larynx and trachea. Then coil. I mean, it always happens. Not for longer than 15 seconds. Slowly intermittent the suction as you withdraw the catheter. Distressed or large amounts of secretion are being suctioned. Partially withdrawn, but remain inside. Covered, ready to continue, yeah. Suction oropharynx with a yanker. Recess the patient mode. Post suction. Appropriate. Okay, hints and suction. To minimize the chance of entering the esophagus, position the patient tilted back. Okay. Patient noted to swallow during insertion of the catheter may slip into the esophagus. In these cases, withdraw the catheter slightly, reposition the patient's head into extension. Okay. Recess the size. Extending the neck. Rotating the head slightly to either side. Head tilt, chin lift, maneuver. Lower the head of the bed. Remove any pillows. Okay, sure. Documentation. Time. Size. Procedural preparation. Description of insertion. A complicated epistasis, difficult insertion. Results of suction, instruction for other staff. This is better. Pharyngeal obstruction, acute pulmonary edema. It's useless because, you know, those fluids are not, you know, we can't drain it. Base skull fracture, yeah, because you may stick it into the brain. OPA only. OPA suction, contract risk of intracranial placement. Yeah. You may be able to puncture the brain. Precautions. Bleeding risk. Platelet to 15, raised INR, raised IPGT. Yeah, exactly. Coagulopathy, warfarin. Okay, hemodynamic instability with like high or low pressure, like blood pressure. Hemoptysis. Acute face, neck, or head injury. Septal deviation. Children, false teeth complications. Okay, these things. Stasis. Who the fuck is? No reference. Complete course, yay! Okay, time is like, haha. I've done 2 of them. Let's see what's next. Okay, time to obscure this. Oh, no, not this one. Obscure this one. And let me check what's next, but you know, I'm gonna end stream here. Ha 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 ha. I did 2 of them, yay! I did 2 of them. Fucking hell. Okay. I'm gonna go take a rest. Thank you so much, guys, for coming in. And I'll see you tomorrow.